Well, good morning. My name is Dr. Irina DeSasia. I'm the Chief Medical Officer of the Quality Measurement and Value-Based Incentives Group, which sits within the Center for Clinical Standards and Quality within CMS. It's a pleasure to be here this morning. Oh, the lights are bright. To speak to you. I'm here to talk with you about one of our initiatives at our agency, the Meaningful Measures Initiative. This was launched in 2017, and I want to give you some context with regard to the work that we've been doing for the last couple of years and future direction with this initiative. This, I think, has a lot of meaning across all our programs within our group. For those that don't know, the Quality Measurement and Value-Based Incentives Group is a group that oversees over 21 pay-for-reporting and pay-for-performance reporting programs. And those programs actually are across a variety of settings, including the post-acute care setting. So I'm going to go ahead and get started with the presentation. Hopefully, I don't know if there will be some time for questions. Happy to take them. So these are some of the acronyms in the presentation for your reference afterwards if you look at the slide deck. And I have no disclaimers. This is really an opportunity for us to communicate with you about our initiative and looking forward to hearing further comments with regard to our initiative. So there are three objectives I have for today as I talk through the initiative. One is to define what it is and what we've done in the last couple of years regarding the meaningful measures. And then I'll discuss the objectives, the framework, and the vision for this implementation piece. We've done a lot of work in the last year in applying this framework across our programs. And I'll talk about our next steps. And then I'll identify resources for you guys to be able to access more information about the work that we're doing online through our website. It's also an opportunity for you to respond, and you can also send us questions. We do look at all of them, so really looking forward of a bi-directional conversation with the work that we're doing here. So what is the Meaningful Measures Initiative? It was launched in 2017, and the purpose really was for us to take a hard look at all the measures across our programs and decide what these measures are doing in terms of the story behind them. Are they actually improving outcomes for our beneficiaries? We see that this is pretty much a partnership between the provider as well as the beneficiary as our end users in making sure that we're delivering toward better care. One of the things that we heard from many of our stakeholders, and this was part of what led to our development of this framework, was that there was a lot of burden associated with the data in terms of submitting the data, the costs associated among providers in submitting the data. And the call was really to take a hard look at the measures that we have within our programs and look at the benefits versus costs of those measures, and are we really driving toward improvement. I certainly will say there are some measures still within our programs that do have burden associated with submitting data, but we feel like the benefits of getting that data outweigh the cost. But it really is a case-by-case basis, but this framework allows us to apply that algorithm. And second, and well, third actually, is really around our alignment piece. This is where a lot of our work that our agency is doing right now around meaningful measures. And this is about aligning our measures across programs along with aligning our measures across other payers. There's work actually happening right now with AHIP and NQF, and we're looking at developing core measure sets across a variety of settings and trying to get to an agreement, because we certainly understand that while CMS has their programs, there are many other payers that are demanding providers to submit data. And as much as we can get aligned and in agreement on that core set, I think we can drive toward better outcomes for all our beneficiaries and as well as reduce burden. So as I mentioned, we're implementing this initiative because of the call of too many measures. The measures really didn't connect. And for us to really look at if we're going to have these measures within our program, where do they fit? And what are we doing in terms of driving toward improving health? We also want to address the effect of the administrative burden of reporting. There's a lot more work in this space happening. We were just last month at HIMSS and talking to many of the vendors with regard to how can we leverage the emerging technology to improve our measurement. And so I think there's a lot of work in that space at this point, thinking our administrator has spoken about trying to get electronic submission of data as much as we can, looking through the use of APIs, looking at FHIR standards. Again, a lot of work in this space at this point. The meaningful measure outcomes also is a way for us to really simplify our focus in terms of critical areas that we want to really move toward improving the care of our beneficiaries. So the initiative was guided by 4 strategic goals, and I have them listed here. These are the goals of our agency, and I'll focus on 2 first, which really led to the birth, actually, of this initiative. One was making sure that we empower patients and doctors to make decisions about their health care. I think this is critical as we look at our measures. We really want to make sure that what we're measuring actually can drive toward improvement. We're spending some time actually also looking at how do we improve the CMS customer experience. So this also speaks to the work we're doing on human-centered design and trying to get our feedback reports back to our providers in a meaningful way in terms of the data they get back. Part of this work also is how do you get the data back timely? Again, all work that we're doing right now with the measures within our program. And the 3rd and 4th strategic goals speak to some of our future work on supporting innovative approaches to improving quality, accessibility, and affordability, as well as figuring out ways that we can have flexibility within our programs as allowed. Many of our programs are statutorily required, but there is some opportunity there as we're looking at the measures and trying to move them forward within our program of choosing which set makes the most sense for our end user. The objectives with our meaningful measures. First and foremost, it was an opportunity for us to focus everyone's efforts in the same quality areas, and it really lends specificity for us to be able to identify those measures. What I've listed here actually are 8 objectives, and I've spoken to this in my previous slides, but I want to highlight a few things here. Our agency is looking toward moving toward measures as much as possible that are patient-centered and meaningful to patients, clinicians, and providers, and are as outcome-based wherever possible. Last year, we had about 42 measures that were patient-reported outcome measures. We're working toward moving more toward that. I think the goal of our administration is to have as many as possible within our programs. Those take time to develop, and then there's challenges with the data submission with those. So a lot of work in that space, but we are trying to get to those measures that matter the most to our patients as well as to providers that are driving toward outcomes. We're trying to also minimize the level of burden for our providers. And so this is really another key piece. Some of our measures within our programs were chart abstracted, and we recognize that many resources were spent by facilities and providers in being able to collect those elements. So wherever possible, if we can, we try to minimize that level with the meaningful measures that sit within our programs. This is another key piece. Many of our measures actually were what we defined as topped out when we were looking at them 2 years ago. And what I mean by that are these are measures that just didn't have variation. Over years, we saw that people were at 95% or more in terms of performing on the measure. And then the question became, well, does it really make sense for us to continue to be measuring this? Now, there are certain circumstances where some of those measures still stayed. So last year in our IPPS rule, for example, we kept measures around patient safety because we felt that was a priority, and we heard from our stakeholders the importance of having them in multiple programs. But then there are opportunities also for us to, not that we don't think those measures are important, but to retire them and put other measures in place that have a significant opportunity for improvement. And this is something that we are doing in terms of our agency of driving toward value. If we're going to have a measure that we're having within our program, we want to make sure it's tied to improvement activities and also where's the return of investment if we are having these measures within our programs. So again, a lot of work in this space you'll see across our programs as we're looking at this and trying to get to this value equation, especially when beneficiaries are trying to decide between providers and facilities and which ones are delivering higher value care versus lower value care. And then, this last two pieces here in terms of the objectives really are with us partnering with our colleagues over at the Innovation Center that have alternative payment models, thinking through ways that we can support measures that go through the continuum and have population-based payment, as well as aligning across programs and payers, as I mentioned earlier. So the framework, again, really was to achieve meaningful outcomes for patients. We didn't do the framework in silo. This really was a collaborative effort. And what I've listed here was really some of the perspectives that we've included as we were developing the framework. This includes the core quality measures collaborative that I mentioned before. We've also worked with our partners across the federal agencies, including the Agency for Healthcare Research and Quality, and many other external stakeholders that have given us input as we were developing this framework. And we also drew on measure work from other networks, so including the Healthcare Payment Learning and Action Network, the National Quality Forum through their high impact outcomes work, as well as the National Academy of Medicine through the IOM Vital Signs core metrics. So I wanted to pause for a second. So we have the objectives that I've described. I've told you about the framework in terms of how we derived it with the multiple external stakeholders that have played a role in us developing this. But one of the things that we also have the opportunity to do within our agency is around quality reporting. And there are many key levers that we can use within our agency with the data that we collect, and we put them out through our Compare website. Some of them also are aggregated into star ratings. And so it's really an opportunity for take the data and to be able to take it from the continuum, from the measure conceptual piece, all the way through and getting onto a website for consumers to use. And, with that, I think here on this slide, what I wanted to emphasize was, one, engaging patients and providers at every step of the process is critical. From the conceptual stage of defining what is the gap in terms of developing a measure to the place of where we get it into our program through rulemaking. And part of this is really making sure those measures are reflecting what's happening on the front line, and again, meaningful if we get this information back to drive toward change. Second is really kind of facilitating the interoperability piece. Last month, we published the interoperability rule. I encourage you, if you have an opportunity, to take a look at it. It's, I don't know, this many pages big. It's quite large if you print it out. So, but it's actually very important if you take a look at it in terms of understanding where our agency is going and wanting to make sure that we strengthen and facilitate interoperability. And this is really taking in a look from the patient perspective that they go across settings, and it's important for them to have information across settings. As an emergency physician, I know that I have to sometimes make decisions for my patients with imperfect information. It's the data that I have at the moment to be able to affect and make those critical decisions in the care of the patient that's in front of me. But we feel like it's important and it's critical that we address this issue and making sure that we have data that crosses settings as much as we can and hold the industry as well as facilities accountable for exchanging that data. And so, in addition, we are optimizing public reporting. There's a lot of work in that space right now. So there's work within the agency to have a single platform where we're going to have all the data. It's like a one-stop shop. Right now, our data is across many websites, especially our Compare websites. So we're working to optimize that reporting and make sure that it's relevant and actionable for beneficiaries. In addition, aligning the portfolio, as I mentioned before, a lot of work in that space and aligning the value-based purchasing reporting as well. So what I wanted to do is actually speak to you about the framework at this point. And so this is actually downloadable as well. It's in our slides, but you can actually go to our website and you can get more information on each of these areas. What I wanted to focus first on this, this wheel that you see here to the right is at the center we have the provider and the patient at the center. And this again is critical for us in our perspective of whatever we're doing with the meaningful measures. measures, it's addressing what's happening at that front line with the interaction between the provider and the patient. And then you see listed there in that blue circle are 4 strategic goals. Surrounding that, you have 6 priority areas, and these are areas that are themes that we feel like are critical with our measures. They should map to eliminating disparities, for example, reducing burden, looking at improving access for rural communities, tracking to measurable outcomes and impact, safeguarding the public health, as well as achieving cost savings. Within that, so you have those 6 areas, and then we have identified 6 additional priorities, and I'm going to go through those right now in the meaningful measure areas underneath them. So one of them is promoting effective communication and coordination of care. This speaks also to our interoperability rule that just came out last month. But the areas that we have around here that we've identified and our measures fit within include medication management. You know, I will say, as I'm looking at those measures within our programs, we can do more there. Right now, oftentimes it's, did you check the medications? Are they recounseled, once they enter a setting or they leave a setting and they're going back to the community? And I think, we're moving toward trying to go from something that's a checkbox measure to one that's actually driving toward outcomes. So there will be more work in that space as we're moving in that area. Second is around admissions and readmissions to hospitals. We've seen tremendous success on this, especially within our hospital-based programs in our group. And this one in particular is looking at, when a patient gets admitted to the hospital and when they come back within 30 days, is there opportunities to improve care coordination. And we have seen some success across hospitals with regard to this measure. And third is around transferring of health information and interoperability. We're working actively in trying to identify measures in that space to be able to see how people are transferring that information and how is it meaningful in terms of whether it's medications or whether it's other informations around care settings that we're actually transferring relevant information to the provider who's taking care of the patient, as well as to the beneficiary for them to know the information that they have. Now, the second area is around promoting effective prevention and treatment of chronic disease. I've listed the 5 meaningful measure areas here, one of them being preventive care. So we have measures, for example, around immunization. We think it's critical that, those especially that are at high risk at immunization, so for example, around influenza. The other is around management of chronic conditions. Many of our beneficiaries have multiple chronic conditions, and how do we actually effectively treat them in a way that prevents further progression of their disease? So several measures around that area, and I'll hopefully have some examples to provide to you a little bit later on with regard to those measures in our programs. And then the third is around prevention, treatment, and management of mental health, along with prevention and treatment of opioid and substance use disorders. We have heard from this administration the importance of addressing head-on the opioid epidemic. We are actively working through the Support Act that just got published last year with regard to getting more measures around opioids in our programs. And there's been a lot of coordination across agencies as well as within our agency in making sure that we have measures that are driving to actually addressing not only the diagnosis of opioid disorders, but as well as the treatment. Mental health, again, another important area. A lot of work. We know that behavioral health is linked to outcomes and being able to effectively address that. We know there are disparities around this as well, and so we're working very much to try to identify meaningful measures across our programs, not necessarily just in our programs, for example, with IPF, which is our inpatient psychiatric facilities, but across the continuum, because we know that it's an important area for us to address. And then the fifth one is around risk-adjusted mortality. We do have outcome-based measures around mortality across our programs, and when we can get those type of measures in the programs, we do feel like it's important for us to be tracking, so that area reflects some of the measures within our programs. Well, the third area among our meaningful measures is around working with communities and promoting best practices of healthy living. And I've seen actually this play out from the conceptual stage of our measures to the point of when a measure gets within our program of really engaging the community and patients as we're looking at our measures within our programs. I mean, we have several of these that we're trying to reflect within communities, and one of them is around equity of care, as well as community engagement. The fourth one is around making care affordable. Now, I spoke earlier about the importance of us driving toward value, and we can't do that without looking at the cost piece. And you'll see that we have measures across the programs looking at appropriate use of healthcare. Another one around patient-focused episodes of care, and the other around total cost of care. Those measures really are for us to take a look at the costs that are blanking on the word. So the costs associated with being able to deliver care, but the most important thing is for us to align them with quality measures. So you'll see a lot of work in this space. If we're going to drive toward value, we feel like it's important that we're aligning our quality measures with our cost measures to make sure that we actually can see what the value is. In the macro program, we've spent a lot of work in the last 2 years developing episodes of care measures around acute and procedural episodes of care. And we're moving in the direction of chronic episodes, and that's the next wave with engagement with subcommittees and being able to conceptualize how do we do this. A lot of important work in this space. I think we need to do more, but I'm quite excited about the work that we're doing here because I think it's critical if we're going to be talking about how do we drive toward value. Then the fifth area is around making safe care safer by reducing harm delivered in the delivery of care. And this includes healthcare-associated infections. Many of our measures around this are through our partnership with CDC and the NHSN. We also have measures around preventable healthcare harm. We are developing measures through the electronic space right now. So there's some that went through our measures under consideration list last year around measures that we can take in assessing harm, but be able to electronically specify it. And this speaks to our effort of trying to get many of our measures in the direction of electronic specification if we can in the next 3 to 5 years. And then the fifth area is around strengthening the person and family engagement as partners in their care. And I've listed some central areas here around making sure that care is personalized for the patient, making sure that end-of-life care is according to their preferences, being able to reflect patients' experience of care. We capture that often through our CAP surveys, but clearly there's more work that we want to do in this space. And the fourth one around patient-reported functional outcomes. We have some successes with this right now. For example, for patients who get a hip knee surgery, we've developed a measure looking at their functional outcome 6 months out after the surgery. But we clearly want to move forward in that direction of collecting elements on how patients are doing and feeling as it reflects to their quality of life. And I know there's been a lot of work through our post-acute care setting in trying to collect these elements as well. So really looking forward to the development of measures in this space. Well, this is the slide again that kind of reflects everything that we're doing. And I think I'm seeing people have them on their laptop and maybe some printouts. But if you want to get some more information with regard to those measures, then let me go back. So I do have a website that I will provide at the end. And you can dive into the actual definitions of each of those meaningful measure areas and examples of those measures. So I know I'm running out of time, but what I wanted to do was to give you an example of some measures that are within our programs as they fit within the larger construct of our meaningful measure areas. So I had mentioned that we have the promoting effective communication and coordination of care. Well, there are some measures that fit within them, and you'll see across our programs that we're addressing medication and management in our quality payment program, through the shared savings program, through a variety of our
post-acute care settings, including IRF settings, LTAC settings, SNF, and home health. And then around admissions and readmissions to hospitals, we have measures not only through our hospital readmission program, but as well as through our ESRD program, as well as through Medicaid and CHIP, looking at readmissions. And then we're trying to develop more measures around the space on the third meaningful measure area where we see some gaps, which is around the transfer of health information and interoperability. And then the second one is around chronic disease. There's, again, the 5 areas that I've listed here, and these are some examples of measures that fit within them. Just briefly, for home health, for example, we have the influenza immunization under the preventive care. I'm going to just quickly go through these. For management of chronic diseases and in our quality payment program, we have measures including looking at osteoporosis management, looking at diabetes management. In addition, through our IPF settings, we have follow-up after hospitalization to mental illness. As I mentioned, we are moving in further direction of developing more measures around the opioid space. We do have some in our Medicaid program right now, but there will be more that will be coming through the pipeline through our partners and trying to really get at this aspect of addressing the epidemic. And then the last one being around the risk-adjusted mortality, and I've listed a measure there in our HVBP program, the hospital value-based program. Well, I know I spoke quite quickly through that, but I do encourage you to please take a deeper dive into those areas. We are looking for feedback. I mean, I see this meaningful measure framework as a communication tool just as importantly as our strategic framework. So really looking forward to whether you think we have those right areas or you think that there's some that are being missed, and where do you see the gaps. So please email the team, and I'll provide the email address for where you can provide feedback as well. So I just wanted to end with just talking about getting to measures that matter. Again, I think it's critical with this framework that we are aligning our measures to our existing programs. I think when we see it from the end user experience, and this speaks to the agency's effort toward human-centered design, the importance of making sure that we have measures that are driving to alignment. So the specifications, what I mean by alignment is specifications as close as possible. There might be some change based on attribution, but the concept is there so people are understanding the concept of what they're being measured. But also an opportunity to stay focused and allowing for clinicians and providers, along with patients, to be focusing on things that matter the most to them and driving toward their care. Where the intent really is to capture the most impactful measures that are high priority across our areas that are driving toward improvement. As I mentioned, another key piece in our work right now is also not as much as driving toward improvement as well as looking at the value associated with these measures. And it's used as a guide to guide us in our rulemaking. So last year, using this framework, we removed 79 measures across our programs and saved extraordinary amount, I would say 80 million in cost. So it was quite a bit of an impact that we had with looking at this framework and looking critically at the measures across our programs. And we continue to feel that these measures will, and this framework will allow us to identify the gaps and to continue to have this dialogue between yourselves and our agency in driving toward change in the health system. So I'll end with giving you some references here. We have a website, so I encourage you to please go and check it out. We have a bunch of FAQs. We also have slide decks there that you can take a look at. We also have definitions associated with these meaningful measure areas. So I welcome you to take a look, and as well as there's a place on that website for you to provide feedback to us. As I mentioned, we do have fact sheets, and this is the link for those. And I think I will end here. I just apologize, I think I'm right at time, if not a little over, but I'll pause for some questions if there are any in the audience. Yes, do you mind coming to the mic so I can hear you, please?
I was just wondering if there was any consideration being given to transportation or non-emergency medical transportation as, excuse me, a social determinant of health.
It's a great question. There is a lot of work in our space and looking at social determinants and how they impact our measures. I will say from a provider standpoint, I personally know the importance of community resources, including transportation, access to food, food security, that play a role in patients' outcomes. Our agency is looking at this. I mean, the struggle is getting elements that we are able to collect in a uniform way across the measures to be able to reflect that. Some work that we have been doing in this space is around dual eligibility. Through the CARES Act that came out 2 years ago, we have used that, and we're mandated to actually look at that across our readmission program. But there's a lot more work in that space, and I would say that follow the reports through ASPE, which is an agency that is looking at social determinants as they relate to our measures. There's one report they came out with in the last year, and I anticipate another one will be coming out in the next year with this work. But I'll have to say with my discussions even with private plans, they are looking at this aspect of how do they get transportation and address those issues to get patients to the care that they need. When you apply it to the measures, part of the challenge is being able to collect that data in a way that's reliable and valid, but also to see whether it makes a difference within our risk adjustment models. There's a lot of work in that space around looking at some of those variables, but we should be able to provide more information in the next year or so with this. But we clearly think this is an important area for us to look at, especially as we're reporting data. We have heard from stakeholders time and time again the importance of being able to stratify based on these social determinants in the population that they're taking care of. So there will be more in that space soon. But thank you for that question, an excellent question.
Did you say ASPE?
ASPE, A-S-P-E. It's an acronym. I believe it's the Assistant Secretary of Planning, and I'm blanking on the E. But if you just Google ASPE, you should be able to find some of their work around this. Dan? Okay. Well, thank you very much.